All right, so welcome to our university seminar series hosted by the GW Institute for Brain Health and Dementia. This topic, the topic for this series is addressing dementia across the public health spectrum. Today is the second lecture in a special subtopic of etiology and epidemiology of selected chronic diseases and dementia risk. So I'm pleased today to introduce Dr. Melinda Power. She's an associate professor of the Department of Epidemiology at the Milken Institute School of Public Health and is the director of the GW Institute for Brain Health and Dementia. Dr. Power is committed to her research identifying and understanding modifiable risk factors for cognitive decline, dementia, and dementia-related brain changes in older adults. Dr. Power is currently receiving funding from the National Institutes of Health and Department of Defense. Specifically, her work considers how environmental pollutants or toxins contribute to accelerated cognitive deterioration in older adults and the complex relationship between life course risk factors and cognitive health. In addition to Dr. Power's research in issues of aging, she teaches graduate courses and mentors graduate students in the Milken Institute of Public Health. So her topic today is called, Do Chronic Diseases Impact the Risk of Dementia? And so thank you very much, Dr. Power, and take it away.
Great. Thank you all for coming. I'm really excited to see so many faces on the call. And thank you very much for that lovely introduction, Keith. Quick plug for the GW Institute for Brain Health and Dementia. Feel free to check out our website and see what we're all about. And as Keith mentioned, this is only the beginning of the seminar series. We'd love to see you all there. So I'm going to start off really broad. I'm going to start off with what is dementia. And dementia is defined clinically, right? It's a clinically diagnosed disease. And it's diagnosed when there's evidence of significant decline in one or more domains of cognitive function that interferes with activities of daily living. So what does that mean? That means that your brain isn't working the way it used to, right? You can think about domains of cognitive function as memory or executive function, your ability to plan and execute those plans. Things like attention, the ability to focus on what's in front of you. And interfering with activities of daily living, these are the things that you need to be able to do to live independently. Feeding yourself, bathing yourself, taking care of your household finances, things of that nature. It's also a diagnosis of exclusion, right? The decline cannot be explained by another disorder. And also specifically, it does not occur exclusively within a period of delirium, which is a dementia-like condition that often happens in the hospital after surgery, although it can happen in other formats as well. Onset is typically after age 60, although there are some forms of dementia that can impact younger people. But really, dementia is mostly a clinical diagnosis about cognitive impairment that was not previously present. So if we think about David and John here, right, these are their trajectories of cognitive function. You know, you're born, your brain develops, you develop better cognitive function, kind of peaks in early adulthood, and then there's this kind of gradual, flattening or lessening over time. Now, if David and John then decided deteriorating, you can see that their cognition is declining from where it previously was, and at some point they'll reach a threshold where they meet criteria for dementia. James, on the other hand, just never achieved that strong level of cognitive function. James would not meet criteria for dementia because he's not falling from a previous high. So if we think about dementia, you've probably heard of Alzheimer's disease or frontotemporal dementia or things like that. It's important to recognize that dementia is the umbrella term, right? So dementia is this clinical syndrome, and people with dementia often have very different brain pathologies. Now, there are a number of types of dementia that we diagnose both based on either clinical symptoms or pathologic correlates. And I'm going to talk quickly about the most common types of dementia in older adults. So frontotemporal dementia, or FTD, is characterized by personality changes and deficits in executive function. And you see frontal and temporal lobe degeneration. So if you look at the picture of the brain here, you notice that on the left, it looks very full, right? This is the back of the brain. Looks very full, very healthy. And if you look at the right, it looks like a shriveled up raisin, right? That's not what you want your brain to look like. That's the frontal and temporal lobe, the neurons dying and the tissue deteriorating. And it's typically associated with protein aggregations of either tau, which we call PIC bodies, or a protein called TDP43. There's also Lewy body dementia that's characterized by fluctuation in cognitions and attention. You also often get features of Parkinsonism or hallucinations. There's often overlap with people who have Parkinson's disease. Parkinson's disease dementia and Lewy body dementia are often very similar in presentation. And then the protein aggregation in this particular type of dementia is usually of alpha-synuclein in the form of Lewy bodies, which are pictured here. There's also vascular dementia. It's characterized by a stair-step progression in executive function and attention, and evidence of cerebrovascular disease. And what I have here on the left, where that arrow is pointing, you can see that little black dot. That's essentially a hole in somebody's brain that's occurred because they've had an infarct or a stroke, right? They've had something that's damaged the brain, and that part of the brain has died and now is no longer full of tissue. On the right, we have what's called white matter hyperintensities. This is another indication of cerebrovascular damage to the brain in most conditions. There are other conditions that can cause similar neuroimaging features. But these white kind of dots at the bottom of the ventricles indicate that the white matter is not functioning the way it should, and usually that is because of a cerebrovascular disease. And finally, the type of dementia that's probably most familiar to most people in the audience is Alzheimer's disease. And Alzheimer's disease, again, is characterized by deficits in learning and memory, as well as protein aggregation of amyloid and tau. So I just want you to kind of keep this in mind as we move through our discussion of chronic disease, because as with any syndromic diagnosis, it's probably not that all exposures or all risk factors are associated with all types of dementia. However, teasing these apart is something that's very difficult to do while the person is living, right? We diagnose these things pathologically in some ways. And so we often kind of go up to relying on that clinical syndromic diagnosis. There's evidence of cognitive impairment. And so the epidemiology can be quite challenging. Another thing to know about dementia is that pathology is often present years prior to symptom onset. What I have on the left here is a figure from a seminal paper from the Rush group. And what they really did is they took cases of people who were clinically diagnosed with dementia during life, and they looked for pathologies in their brain. And that's what you see in panel A, right? Very few of those people had no pathology. A lot of them had Alzheimer's disease. Some of them had infarcts, which are an indication of vascular dementia. Some of them had Parkinson's disease and Lewy body disease. A lot of them had more than one pathology going on. And then the novel thing that they did, which seems obvious in retrospect, is they said, well, let's go look for these pathologies in brains of people who are not diagnosed with dementia. And lo and behold, while there were a number of brains, about a third of the brains had no dementia related to pathology, the other 2/3 did. There was a lot of pathology that was in the brain that had not quite progressed to the point where we see symptom onset. And so if you think about dementia, dementia is a disease with a very long preclinical phase where changes are happening in the brain, but they're not yet detectable in terms of the cognitive symptoms that we associate with the condition of dementia. And people in this preclinical phase may have either pathologic changes that are not severe enough to impact cognition, or they might have a brain that's just chock full of pathology, but for some reason that we don't understand very well, they're resilient to the adverse effects of this pathology. They can compensate and they don't have those clinical symptoms. So in this context, it's clear that exposures over the entire life course can impact dementia risk, and they can do it in a number of different ways. So we can think of dementia as usually onset after age 60, so in late middle age to later adulthood, and that this disease initiation, disease progression has been happening for many years, right, before we have those clinical symptoms. And so it makes sense that anything from childhood through later adulthood could impact the either initiation, progression, or appearance of symptoms of this disease. And if we think about, this disease initiation, disease progression, clinical symptoms, exposures can also impact risk of dementia by either changing the disease etiology, right? Making it start, making it progress faster, making it progress slower, or that idea of resilience and reserve, right? People have pathologies in their brain, but somehow it's not manifesting as clinical symptoms. It's not manifesting as cognitive impairment that's severe enough to cause debility. So keep that in mind as we talk through our risk factors today. So for today, I'm going to focus on a couple of chronic diseases, right? Does chronic disease impact dementia risk is our question of the day. And I'm going to focus on these four: cardiovascular disease, cancer, diabetes, and depression. There are a number of other things that people have looked at. And if people are curious about a specific chronic disease, I'm happy to share whatever it is that I know about it at the end of the talk during the Q&A section. So if we think about cardiovascular disease, let's just take a step back, right? Make sure that we're all on the same page about definitions. For the purposes of this talk today, I'm going to include cardiovascular disease defined as including heart disease. So this is atherosclerosis of the coronary arteries or other vessel disease, myocardial infarction or heart attack, all different kinds of heart failure, arrhythmia, peripheral artery disease, and cerebrovascular disease, including stroke. So if we take what we've thought about so far, it seems pretty obvious here that at least, cardiovascular disease is related to dementia risk in that stroke and vascular dementia are related to dementia risk. So if we think about this, stroke and subclinical cerebrovascular disease, the evidence is very clear that impacts your risk of dementia, right? Having a stroke can put you in, can change your cognition such that you are now diagnosed with dementia. And if we take it a step back, there's also evidence for subclinical cerebrovascular disease to be causing dementia. So there's strong evidence of an effect of atherosclerosis on the cerebral arteries and vessels, leading to cerebrovascular disease, which includes stroke, but also subclinical effects, things like those white matter hyperintensities that show damage to the white matter, but didn't cause overt symptoms of a stroke. Things like microbleeds in the brain, things like lacunar infarcts, which are basically the same mechanisms as stroke, but again, don't rise to the level of causing symptoms that would get you to the hospital. So it's pretty clear here that cerebrovascular disease or stroke causes cognitive impairment due to the damage to the cortical tissue, and that subclinical cerebrovascular disease can also cause damage to the brain, resulting in cognitive loss. Now, whether cerebrovascular disease has an effect on types of dementia other than that vascular dementia category I mentioned remains unclear. There are some studies that suggest, having cerebrovascular disease also makes you more likely to have Alzheimer's pathology. There are other studies that don't suggest that. I think the jury is still out about whether this is a straight pathway from, cerebrovascular disease to brain damage to dementia, or whether there's something going on that we can link to other kind of dementia pathologies, other protein aggregations that are happening in the brain. So if we take a step back, it also would make sense then that cardiovascular disease risk factors also are related to dementia risk. And that evidence, I'll review some of this here, but that's pretty clear. There's pretty clear evidence that cardiovascular disease risk factors lead to atherosclerosis and inflammation, lead to stroke and subclinical disease, and straight to dementia risk. But there's also kind of a growing body of research suggesting that cardiovascular disease risk factors might directly impact dementia risk external to some of these other pathways. And it's still an area of active investigation. So cardiovascular disease risk factors that have been linked to increased dementia risk include high blood pressure, high cholesterol, smoking, diabetes, obesity, and low physical activity or physical inactivity. And I'll talk about a couple of these today. So the first is hypertension and dementia risk. This has been well studied in the epidemiologic literature for a number of years. And there's a very clear pattern that emerges, and it's an interesting one, right? It's not just as simple as hypertension associated with dementia risk, yes, no. It seems to be age dependent, right? So there's this idea that midlife hypertension, if you have hypertension when you're 40 years old, 50 years old, you have increased risk of dementia when you're 70 or 80 years old. But if we turn around and we measure hypertension in people who are already 70 or 80 years old, it doesn't seem to increase their risk of dementia, in that older adult period. Now, part of this could simply be an effect of duration, right? That hypertension, is a cumulative disease. The pathogenesis of dementia takes many, many years. And so your hypertension right at this moment isn't going to increase your dementia risk until 20 or 30 years down the line, just because it has to have time to act through that long, slow pathologic process. So that's one explanation. Another explanation could be that in late life your vessels are kind of stiff and you really need a slightly higher blood pressure to maintain adequate blood to the brain. I think we are we're kind of landing a little bit more on the duration side of things, but it's still an active area of research. So if we think about the studies that have shown hypertension dementia risk, it actually gets even more complicated because it's also the patterns of blood pressure over time. So what I have here on the right is a table from a study in the Atherosclerosis Risk and Community Study, or ARIC study, which is a cohort that I use data from quite a bit. And what they did is they looked at the association of blood pressure patterns over 24 years of follow-up and the association with incident dementia. And I want to highlight here, they're using people who have normal blood pressures at midlife and late life as the reference group. And then they're comparing people who have different combinations. That first row is people who had normal blood pressure in midlife and had late life hypertension. And you can see that the hazard ratio there is 1.16. The confidence intervals include the null. We conclude there's no real increased risk going on with that group. The next group, though, has hypertension in both midlife and late life. So they've had hypertension for quite a long period of time, right? So if they're hypertensive at those 2 time points, they're likely hypertensive the entire way in between. And you see about a 50% increased risk of dementia in that group relative to the reference group. Midlife, normal blood pressure, and then late life hypotension, which means blood pressure that's too low, not associated with any increased risk. But then interestingly, midlife hypertension followed by late life hypotension, so high blood pressure followed by low blood pressure. Again, we see about a 60% increased risk, saying that perhaps this could be high blood pressure leading to damage that leads to low blood pressure. Actually, if you're seeing evidence of damage due to this hypertension, you see even increased risk of dementia. We see similar patterns for cholesterol and dementia risk. In observational studies, high cholesterol in midlife appears to predict late life cognitive loss, late life less so. And so again, we have another paper here. This is a figure from actually my own work at the ARIC study. And you can see here on the top that people with high cholesterol have greater difference in their 20-year decline in DSST scores. Okay, so what does that mean? It means that people who have high cholesterol have declined more over 20 years in terms of their cognitive function, measured by a tool called the digit symbol substitution test. So if we go back to our definition of dementia, right, you had to see decline from a previous level, and that's what we're measuring here. We're measuring that rate of decline, and we're saying that people with high cholesterol in midlife have declined more over the subsequent 20 years than people who did not have high cholesterol. We see a similar association for LDL cholesterol, although that highest category is a little funky. Not so much with HDL. We would expect HDL to be protective, not seeing that here, and that's pretty consistent with the literature. And we'd expect HDL protective because it's protective against other cardiovascular outcomes. Same thing with triglycerides, right? Clear dose response here, higher triglycerides, worse cognitive decline. And then for reference, we also put the associations with blood pressure. So you can see it's on par there. More current studies have not seen as much of a risk of high cholesterol and dementia. And personally, I think this may be because of the wide uptake of statins. Statins came onto the market in the late 1980s. They treat high cholesterol and have all sorts of other beneficial effects for cardiovascular health and health in general. And that's an area of research that I'm trying to get going to see if we see what this uptake of statins has done to population level risk associated with high cholesterol. So we've talked about this, right? We've got the CVD risk factors going through atherosclerosis, inflammation, stroke, and subclinical cerebrovascular disease to dementia risk. That pathway seems pretty solid. We're pretty confident about that one. But this dotted red line, right? Do cardiovascular disease risk factors influence dementia risk independent of these other mechanisms? It's a little less clear, right? So what we have here is an association between blood lipid levels and visit 5 amyloid burden. And for those of you who are current MPH students, this is actually a paper that was done and published by my student Erin Bennett as part of her practicum and CE work for her MPH. So if you're interested in these topics, there are opportunities to do research with our faculty. And what she found here was that there's really just no association between blood lipid levels and amyloid burden. And remember, amyloid is one of the proteins that aggregates in Alzheimer's disease. So what we're trying to say here is, we know that blood lipid levels probably influence dementia risk through kind of a cerebrovascular pathway, but what about through an Alzheimer's disease pathway? And we just don't see much evidence here, right? If we were to see evidence, these lines would be, not flat across the charts. We would see something where as your total cholesterol or your LDL increased, your global SUVR, which is a measure of amyloid burden that we can see in the brain using PET neuroimaging, would also increase. And that's just not what we found. So, and then this last piece we have, when we're thinking about cardiovascular disease and dementia risk, I read you a whole list of cardiovascular disease, when I define cardiovascular disease, a whole bunch of things: heart attack, heart disease, arrhythmia, heart failure, peripheral artery disease. I haven't talked about those yet. And that's because it's really hard to disentangle whether those things impact dementia risk directly, or whether it's because all of these shared risk factors and shared underlying pathologic changes, atherosclerosis and inflammation, whether those are really the things that cause any sort of association between these other cardiovascular disease outcomes and dementia risk. So this is also an area of research that is currently going on. And this just repeats what I just said, right? Heart attack, heart failure, arrhythmia, peripheral artery disease may directly contribute to dementia risk, but it's really difficult to disentangle this from shared risk factors or shared underlying pathologic changes, talking about that atherosclerosis and inflammation associated with the CVD risk factors. So the next step, right, would be, well, okay, if this chronic disease impacts dementia risk, maybe we should treat it, and maybe that would help. But interestingly, RCTs have failed to find cognitive benefits of treating high blood pressure. There have been a number of studies of blood pressure reduction that mostly had primary outcomes that were for cardiovascular disease, but then they had a secondary outcome that was cognition or dementia. SPRINT is just the last one in a long line of RCTs of this nature. And what we see here is that there's a suggestion, right? You see that hazard ratio of 0.83, suggesting that lowering blood pressure, the intervention group here was to have lower blood pressure targets versus standard blood pressure targets. That group did seem to have less risk of dementia, but the confidence intervals include the null, so we can't be that conclusive. There was an effect with mild cognitive impairment. That wasn't the primary outcome of this sub-study. Mild cognitive impairment is also pretty subjective. So although that's a significant effect, this study is considered to be a null study by many. So it's a tricky thing to understand. We'll see what happens here. One of the things that might be going on is that SPRINT and many other studies of blood pressure lowering have really been stopped for efficacy on cardiovascular outcomes, right? So the study was supposed to go for 5 years or 6 years, stopped after 2 because there was such a dramatic benefit to cardiovascular health. And so it's not really clear here. If we lengthened these studies, would we have found significant results? I don't know. A lot of people believe yes, some people are skeptical. So we'll have to wait and see. Unfortunately, we're not going to get longer term studies of blood pressure reduction because it's just not ethical to do that. So we're going to have to rely on the observational epi to help us solve this problem. We have similar problems with cognitive benefits of treating high cholesterol. There have been 2 big randomized studies of statin use. Again, primary outcomes were for cardiovascular disease and mortality, secondary outcomes on cognition or dementia. And what we found was no difference in cognition in the short term, right? We treat people for somewhere between 3 and 5 years with statins, and we just don't see any benefits on cognition in that time period. Now, whether that's because, remember, we talked about dementia having this super long prodromal period, this long pathogenesis, maybe treating people for 2 years just isn't really enough to move the needle that much, or it's not enough to move that needle that soon, right? If the progression is already happening, if cholesterol is a part of disease initiation, treating someone who's already on the pathway to dementia and lowering their cholesterol at that point, it's not even clear that you would expect a benefit. So in summary, cardiovascular disease and dementia. Cerebrovascular disease is a known cause of dementia, it's uncontroversial. But whether CVD or CVD risk factors impact dementia risk through other pathways remains unclear. The sustained and successful treatment or prevention of CVD risk factors seems like that should impact dementia risk. We've yet to demonstrate that in a trial. And there are some people who believe, maybe it's not the CVD risk factors at all, right? Maybe it's the common causes of genetics, diet, exercise, and social determinants of health. And I think some of our later speakers are going to get into more mechanisms about diet and exercise and how they might be related to cognition and dementia. And I'm personally looking forward to that talk. I hope you'll attend as well. Okay, so I didn't mention diabetes as a cardiovascular risk factor because although it is, it's also its own disease in its own right. And diabetes is one of those risk factors where the link with dementia is pretty clear, right? Study after study, no matter when it was conducted, what population, what age group, diabetes is pretty consistently associated with increased dementia risk. So for example, here, what we have here is a forest plot of a number of different studies, as well as a meta-analytic summary estimate. So if we start at the bottom, this Liebson 1999 has an effect estimate of 1.59, that's that black box. The size of the black box is proportional to the size of the study, right? So this had a lot more people than some of the other studies. And then the gray whiskers are the 95% confidence intervals. The gray line that goes up from 1, that's the null, right? The dotted line is where that summary estimate is. You can see it lies in the middle of all of the individual estimates. So study after study, some of these studies were null and that their confidence intervals crossed the null, but none of these studies found protective point estimates or truly null point estimates. On balance, diabetes consistently associated with dementia risk. We also see this sort of pattern when we look at measures of how well the body is processing glucose, right? So diabetes is a disease of glucose, of poor glucose regulation. HbA1c is a measure of kind of the past 3 months glucose regulation. Higher HbA1cs are worse. And what we have here, this is another study from the ERIC cohort. We see that compared to people with HbA1cs less than 5.7, people with higher HbA1cs have greater cognitive decline over 20 years, right? Faster cognitive decline over their middle age to later adulthood. You can also see that here it's true even for those in the pre-diabetes and undiagnosed diabetes levels, as well as those who have HbA1cs that place them into the diabetic category. Now, interestingly, the RCTs again don't give us a clear path forward to what to do about this, right? So a CORD trial was a randomized controlled trial of participants aged 55 to 80 with type 2 diabetes, an HbA1c over 7.5%, and who were at high risk of cardiovascular disease events for a variety of different reasons. The intervention was to target the HbA1c to less than 6%. The standard was to keep it between 7 and 7.9. And what we have here is the outcome that they chose to focus on was DSST scores, right? Moving away from dementia for the reasons I said above, right? Dementia is probably the end result of a 20-year process approximately. So in a trial that's only 2 or 5 years, maybe we need something that really gets at that decline that's happening, maybe not necessarily all the way to the place where you have dementia, but maybe we can look at that cognitive change. And again, here we're doing it with that digit symbol substitution test. It's a great test for those statisticians or people who are statistically minded. It's normally distributed. It's got really good differentiation between people. It's just a beautiful test to use in epidemiology. And it has shown in a lot of observational research to be related to diabetes or other cardiovascular risk factors. So if you can see here at baseline, the randomization did what it was supposed to do. We have similar DSST scores on average in the intensive treatment and standard treatment groups. At the 20-month follow-up, you can see that the intensive treatment group is doing a little better. Higher scores are better here. But at the 40-month follow-up, there was no significant difference between the groups. So ACCORD says that there's no benefit to aggressively treating diabetes on cognition. And interestingly, ACCORD is one of those trials that really surprised everyone because it was also had unsurprising conclusions about the effect of the intensive treatment on mortality, CVD, or cognition. You actually saw more mortality and more cardiovascular disease in the intensive group than you did in the standard group. So I think there's more to be done here to kind of tease apart what's going on and see if we can't find a better way to address the fact that diabetes seems to increase risk of dementia. At this point, my goal would be, my advice to you would be try not to get diabetes. Try to think about the risk factors for diabetes and avoid those, right? Be physically active, watch your diet. If you have a family history, talk to your physician about other things that might be useful. So in summary, diabetes appears to increase risk of dementia. And right now, our best advice is prevention, right? ACCORD had poor results for the aggressive management of HbA1c and no impact on cognitive health at the 40-month follow-up. So let's move away from cardiovascular disease and dementia and talk about cancer, right? So cancer is an odd duck because people who get cancer don't get dementia. It's really weird, kind of cool. Love to know why. So what we have here is we have another one of those forest plots that I talked about. You've got each of your estimates. In this case, we're saying if you have cancer, you have lower risk of dementia. That's what we're finding. All of these point estimates are less than 1, indicating that the effect is protective. We see this for case control studies. We see this for cohort studies. You can see the subgroup hazard ratio that I've highlighted of 0.81 with confidence intervals that exclude the null. Say about a 20% reduction in risk of dementia if you've had a cancer. And what's really interesting here is that it's true even for non-melanoma skin cancers, right? Non-melanoma skin cancers don't kill you. They don't tend to kill you. So early studies that found this, everyone was like, oh, well, it's just because people who have cancer, have lower life expectancies. So they're not at risk of dementia because they don't live long enough. But that doesn't seem to be the case because we see it even for non-melanoma skin cancer, where most people survive. It's not a big contribution to mortality. So why this is, no one knows. It's something that I think needs a lot more work. There's some suggestion that there's upregulation of pathways during cancer that might protect against dementia. There's some suggestion that maybe there's some genetic, predisposition that makes you more at risk of cancer, less at risk of dementia. It's really not clear. And I think this is a really interesting area that I'd love more people to look into. So in summary, people who develop cancer appear to be less risk of dementia, and we have no idea why. Seems like something we should try to look more into. And then the last risk factor I'm going to talk about today is depression, right? And depression is a tricky one because it's really difficult to disentangle which way the potential causation is going, right? So in one hand, we could think about depression as having an influence on dementia initiation, dementia progression, so actually impacting the disease process. That makes sense, right? Because depression is a disease of the brain. We've got different neurotransmitter levels. We don't really understand depression all that well, but we know that it has a biological basis in the brain. And perhaps those changes, those biological changes in the brain associated with depression also put you at greater risk of initiating or developing that protein aggregation that ultimately leads to dementia. There's also some evidence that depression impacts that resilience reserve. So for a given level of pathology, do you have cognitive symptoms? Number of studies that suggest that. But then we also have depression maybe as an outcome of the pathogenic process, right? So maybe the changes that are happening in the brain impact mood in addition to cognition, right? And maybe the cognitive symptoms, maybe being frustrated or being aware in whatever way that your cognition is not what it used to be might predispose you to having mood symptoms. So there's also pretty strong evidence of a direction this way, that the underlying pathogenesis of dementia leads to depression. And then finally, there's a number of common risk factors for both depression and dementia that, whether they're genetic or environmental, might lead to both. And it's really difficult to disentangle this from the prior two hypotheses, in part because we understand very little about how depression comes to be and what that disease looks like. You think dementia is complicated, anxiety, depression, psychiatric disorders are even more complicated to understand. And so there's also a lot of potential for these common risk factors to influence, all of these different things, thus creating a link between them where there's no actual causal link at all. So I think the jury is still out in terms of exactly what depression and dementia risk looks like. It's probably a combination of all of these different things. So the arrows get pretty complicated pretty fast. So in summary, the relationship between depression and dementia is complex and likely reflects multiple pathways, right? Depression is a result of dementia pathogenesis, dementia as promoting dementia or lessening cognitive reserve, and depression and dementia sharing common risk factors. So I've talked about 4 chronic diseases, but there are others that people have highlighted. This is a figure from the Lancet Commission 2020 report on dementia prevention, intervention, and care. And what it does is it highlights risk factors that have reasonably strong evidence of being related to dementia, and then tries to put a number on, what we could do to dementia risk if we could modify these different risk factors. And while I personally don't love the set that they chose, I think there's some things that are in here where the evidence is a little shaky. I think there's other things that are missing that need to be on this chart. What I want you to take away from this is that there are a number of things that are potentially modifiable in terms of dementia risk. We think that there are risk factors that we can change that would reduce your risk of getting dementia in late life. And a lot of them are chronic diseases, or they're things that lead to chronic diseases, right? So you've got hearing loss, traumatic brain injury, you've got cardiovascular risk factors of hypertension, alcohol, obesity, smoking, you've got depression and physical inactivity. And so a lot of these things, it all kind of comes down to physical activity, diet, social determinants of health, and genes, right? Ultimately, that's where we end up. If you're in epidemiology long enough, the answer is those 4 things. But we can intervene along the way. And one of the places that's exciting to intervene on is these chronic conditions, because these are things that other people are working on figuring out how to treat. And if we can piggyback on their work, maybe we can make a big difference in dementia risk. And there's some evidence that we're doing that. Dementia incidence and dementia prevalence are actually going down in the developing world or developed world. So the incidence of dementia is lower than it used to be. Now, it's great news, but it's also not going to stop the growing dementia pandemic or epidemic, because the sheer number of people who are aging into the age of risk of dementia is growing just because of population aging. And so more and more people are going to be affected by dementia as we go, even though the incidence has dropped a little bit over the last couple of decades. I also want to highlight here this hearing loss bucket. I haven't talked about that at all today. My colleague and friend Jennifer Deal will be talking in a later presentation on this, and it's really fascinating. I encourage you all to join us for that one as well. So my conclusions for today, chronic diseases and chronic disease risk factors do appear to impact dementia risk. Even where there's uncertainty, there's little downside to promoting standard chronic disease prevention and management for the benefit of brain health, right? What's good for your heart, going to be good for your brain. You might as well do it, right? All the other things that I talked about, there's little downside to saying, hey, maybe we should treat depression. Maybe we should treat diabetes. Maybe we should try not to get cardiovascular disease or diabetes or depression. There's a lot here that we can advocate for that, even if there's uncertainty, it's not like this advice is controversial. We're going to be doing it for other reasons anyway. Modifying those upstream causes, diet, physical activity, and social determinants of health really has a great potential to improve physical and cognitive health. And so I think that ultimately that's where we're going to want to spend a lot of our time. And then finally, underlying mechanisms by why these chronic diseases are linked to cognitive change and dementia is really going to help us identify effective drug targets. And I'm really thinking about cancer. Right? Why is there that inverse relationship? And if we could harness some of those changes, if it really is changes that are happening as a result of the cancer in the underlying biology of our bodies, maybe we can hijack that machinery. Maybe we can hijack those changes so that we can have that benefit without having to have cancer first, right? I think that's a really interesting area of research. So I want to thank you for your time, and I am happy to entertain any questions that you have.
Thank you so much, Dr. Power, for that great presentation. If people have questions, they can just enter it into the chat and we can read it out loud. Otherwise, feel free to unmute yourself and ask.
I have a question, Melinda. With regard to your behavioral modifications, what do you think would be the ultimate time to intervene? with regard to prevention of dementia based on everything you talked about today?
Now, start now. I don't care if you're 20 or you're 60. There are
I was going to say in utero, but okay.
Right? I mean, I think there's so much, we've got the whole life course, right? Everything that, dementia and other age-related diseases, my first question when I started being interested in these was like, wait, why do we get these when we're old? And you know what? Nobody has really been able to answer that question to my satisfaction yet. I can't even answer that question to my satisfaction yet. But it does mean that we have our entire lifetimes to influence the risk of these diseases. And we should think about it that way. We should think about what are the things that we can do to promote health and well-being in utero? What are the things we can do to promote health and well-being in childhood, in middle age, as you're growing, or even, maybe you're 70 or 80, what can I do right now to maintain my cognitive health as long as I can, right? Everyone wants to live independently. People want to maintain their cognitive health, and there's things that you can do. My best advice for you is, it's like beating a drum, right? It's always diet, it's always exercise, it's always taking care of yourself. If you have a chronic condition, managing it to the best you can, right? Take care of your own body and your own mind. And so for all of you who are out there, if you want to make a change to yourself, it's going to be good for you. And if you want to recommend to other people, start now. It's never too late, and it's never too early.
Looks like we have a couple of questions in the chat as well. So any evidence that depression medications contribute to development of dementia? And then also interested in the same question, but in the context of cancer medications. The term chemo brain comes to mind.
Yes, so both of these I know are very active areas of research. I am not aware of any evidence that depression medications contribute to the development of dementia. I might see if Keith wants to jump in there, but my sense is that there are issues with multiple medications and drug interactions and things like that can impact cognition. But on should I treat my depression with medications? I think we come down on the side of yes, right? So those are separate issues. A lot of times older adults come in with, this list of 17 medications that 18 different doctors have given them. Actually, that would be a little silly if you had 18 doctors and 17 medications, but anyway, you see what I mean? And they interact with each other and they can have cognitive issues. But on the other side, yes, treating your depression, I am not aware of any evidence that that's putting you at more of risk of dementia. Anything to add there, Keith? I know this is more your area. Yeah, okay. Yeah. And then chemo brain, yes, there are definitely cognitive consequences of cancer and cancer treatment. But again, those types of things are, they're known side effects. They're not probably the same mechanisms as dementia, right? There's things that are influencing your brain chemistry and things that are influencing how you think. But I'm not, you still want to use those. You still want to treat your cancer, and then we're going to work on how to figure out how to undo some of those kind of chemo brain things. Our former colleague Hannah Aram was working on this, and it's really an interesting area of research.
And then the next question is, how do you see future research focusing on the relationship between cancer and dementia? Are there any current studies on the topic that are particularly interesting to you?
Yeah, same answer, to be honest, right? Starting to think more about the biology. We've got this interesting thing. We've replicated it in multiple settings. Now we still need to start drilling down, like, what are the pathways? What are the pathways that are upregulated or downregulated? What are the shared genetic predispositions, the SNPs that might underlie this? I think going back down to the molecular is the place to go here for cancer.
And then slightly different, contraceptive use in women and dementia correlation. We've seen heightened risk of psychiatric disorders in children of women who use OC, but curious of the women themselves.
I'm not sure about this one. I don't know about oral contraceptive use. Like the in utero question is very, very interesting. I do not know of any papers on that. I know that the WIMS study did WHI was a large cohort, large randomized trial of oral contraceptive use on cardiovascular health, and I believe they had a dementia outcome. I would want to double check, but I'm pretty sure that one was null. So I'm gonna punt that, and if I have a chance to Google it and let you know by the end of the presentation, I will. Do I think CVD risk factors may contribute to racial disparities in dementia? Yes, I do. We see a lot of racial disparities in cardiovascular risk factors. We see a lot of racial disparities in cardiovascular health, and we see racial disparities in brain health. And those, it's hard not to draw lines between those things. There are some interesting research about things like ApoE is a genetic risk factor for dementia. Doesn't seem to have as much of an impact in the Black or African ancestry populations as it does in the Caucasian white populations. So I think there are some other things that need to be looked into, but this, especially in the United States, these health inequities, you know, you see them in every disease, right? You see them in cancer, you see them in childbirth, you see them in cardiovascular disease, you see them in dementia, and I think they're all linked to each other.
Read this next one. It says, given the long preclinical phase of dementia, and because most of the tests like MMSE are designed for diagnosis of dementia once the patient gets symptomatic, will it be helpful to get early screening tests for dementia, especially targeting those diagnosed with these chronic diseases?
Yes, so this is a really interesting question. Thank you, Amarpali. I'm going to give you my opinion, and I want you to very much understand that this is an opinion, because there are people on both sides of this question who would argue vehemently for or against. Personally, I do not think that having a screening test for dementia is terribly useful, because there is not much that we can do, right? We can't, I know that there was just drugs, Aduhelm was just approved by the FDA, it's very controversial. There's nothing we can really do to prevent the disease process. Now, on the flip side of that, I do think people should be having conversations about what they want their end of life or late life to look like, right? I think people should be thinking about, how am I going to pay for long-term care if I end up having dementia? I think people need to think about, what are my end of life needs? People need to think about, okay, well, if mom has some cognitive loss, how are we going to deal with that? And to the extent that having screening tests prompts those conversations, I think it could be useful, but that needs to be a personal choice. There are tests that can look at, are more sensitive to changes in cognitive impairment. They need to be given serially. It's not very clear that this is easy to do in the current clinical environment. It's something that Medicare now pays for cognitive screening, so that's something we could do. There are scans like amyloid PET scans. You can see if you have amyloid pathology in your brain. Personally, that would just make me an anxious ball of goo, because having amyloid in your brain doesn't mean that you're going to have dementia tomorrow, right? You may well outlive the effects of your amyloid in your brain. So a lot of opinions there, a lot of wrapped up. It's an active area of debate in this field. People feel very strongly one way or the other, but that's my 2 cents.
So the next question is there Burgonian research in the long time period before diagnosis? Scheduling scans, cognitive testing analysis, what periods to see specialists due to lack of specialists and increased demand?
Yeah, so I think that when I'm talking about the long time period before diagnosis, I'm talking about a period of 20 years where changes are happening in your brain, where you don't know it, right? So this unlike other diseases where there's real, and we also have a very little treatment that we can do for most forms of cognitive impairment. So I think, yes, the scheduling scans, cognitive testing, analysis, wait period to do specialists can certainly be harmful in that, if you are someone for whom having a diagnosis is going to be valuable, right, because it helps you with your work life or it helps you with your planning, yes, that's frustrating. But in terms of the prodromal period of dementia, I don't know that this is those two questions kind of interact as well as they might. And if I've misunderstood your question, feel free to try again, and I'll try to answer again.
And I love this, some disagreement. So Armand could unmute if he wants to, but delaying disease progression via things like hearing aids, added exercise, and even simple engaging activities seem like promising enough reasons to be screened ahead of time. Question mark.
Yeah, no, I mean, yeah, if that's what you need to get motivated to do these things, then by all means. But I mean, I'm probably personally, I'm gonna be motivated to do these things because I don't want to have a heart attack and I like to hear things. So yes, I mean, I think if this is what you need to be motivated to have these healthy habits, then by all means, feel free to screen.
And then some clarification to the previous question. I'm talking about the time period for patients between experiencing symptoms and having to wait for months in just a holding pattern.
Yes, no, I feel for you. That's frustrating. And if you are a person who's seeking diagnosis and sees benefit in that is certainly not useful. There are actually, the diagnostic process can be helpful because it does open doors to a lot of services, which is a different question than screening, right? So getting a diagnosis potentially has some real tangible benefits, and I can see how frustrating this would be. I'm not a clinician, so I'm gonna step away from commenting on that further. I know there are a couple clinicians on the call, so if anyone wants to jump in, feel free.
And then I actually have a sort of a finer detail question. So I think in 2017, the cutoffs for hypertension decreased. Do you know if what values that they're using in that literature?
Yeah, so basically the story with hypertension has been a creeping lower and lower is better, right? We are constantly pushing the targets lower. Sprint was a target of 120 or less, and versus a target of 140 or less. And so I think Sprint for cardiovascular health was a very clear message that we should be trying to push people back into that quote unquote normotensive range.
So seeing no more questions, again, thank you, Dr. Power, for this excellent second session for our seminar series. I just do want to put a plug in for the GW Institute for Brain Health and Dementia. Please visit our website and follow us on Twitter. And also a plug for the next session that will happen. That's going to be on December 1st with Dr. Jill Barnes from the University of Wisconsin. And in that, she will kick off our section on biological mechanisms of dementia. And so lots of great other things to come. And thank you, Dr. Powers, and thank you everyone else for attending.